today is Diego Diaz. He is a physical therapist, and I'm going to let him tell you a little bit about himself. So if you want to tell me a little bit about your background, where you're from, some of your specialties.
Great. Yes, my name is Diego Diaz. I'm a physical therapist. I have, wow, it's gonna be 17 years of experience now in April. I'm from Colombia. I'm bilingual. I speak Spanish. That's my first language. I'm a U.S. citizen as well. My background in therapy started from the beginning in neurological with neurological patients and pediatrics, and that was my beginning in this rehabilitation world. It's been since the I think I was chosen to be part of the neuro world, and very happy to help kiddos, children, adults with neurological impairments. And thank you so much, Jenny, to invite me for your podcast. I'm very excited about what
Yes.
we're gonna discuss today.
Yes, I'm super excited. So Diego and I have we kind of connected over social media, and we practice a lot of, like, we're both trained in neural developmental treatment. We both do intensives, constraint, induced movement therapy, and a lot. We love our electrical stimulation and whatnot. So we always have good conversation. I really am excited that you're here. You are one amazing therapist. You have great skill
Thank
level,
you.
and
Likewise.
love seeing your results with your kids. So cool and just exciting just to see. I think a huge thing is, and we'll get more into that later about, like, the dynamic flex casting. But that's something I don't personally do, because I am an occupational therapist, so I know I can't be trained in that. But I'm so big on my alignment and stuff, and I think a lot of times that's like a missing key component. So I'm super excited for you to kind of talk about that as well. Um,
Yes.
but let's kind of dive a little bit into neural developmental treatment. And what did you get trained in that? And did you feel like that kind of made a major change in your treatment? And if so, how? So we
Very
can kind of,
so yes. So I think I was very lucky. I'm a foreign therapist, so I was very lucky when I was in college that my teachers, when they were taught their subjects in neurological development, neuroscience, and whatnot, they were NDT trained. So NDT was from the very beginning in my college years, and after that, I started working in in outpatient clinics, and I might say maybe 50, 60% of therapists they were NDT trained, because where I'm from, NDT is a huge thing. You must be NDT trained in order to be able to work with neurological clients. If you don't have NDT trained, it's like you're less a skillful therapist. Let's put it that way. So NDT is a big thing in Colombia, in South America, where I'm from. So I think NDT shape from the very beginning the way that I see clients, the see that I see their issues, their alignment, and from the very beginning is been part of all my treatment sessions, regardless of the tool that I use or the technique that I use with NDT. I start always from NDT. NDT is everything to me. Like, if you compared nowadays with evidence based, right? That they say, okay, if a child is not able to walk by the time they turn 2 to 4, they're not gonna be able to walk. But being NDT trained and have the experience that I have seen kiddos started to take steps even when they turn 7, 10, 12 years of age. Because when you're NDT trained, you need to think about, it's not about the diagnosis as a cerebral palsy. You need to think about what's the type of cerebral palsy that the child has. What's the tone that the child has? It's very different if you have a child with hemiplegia, right? That you might expect this kiddo to walk from 1 to 2 years of age versus a child that has diplegia, right? It's gonna take a little bit longer. They start to take steps from 2 to 4, right? But what happens when you have ataxia? Those kiddos gonna take steps. It's gonna take longer. They might use a walker before they're able to take a step. But kids with dystonia, those are the ones that the most that I encourage the parents. a lot when they have kids with dystonia to not give up, because these kiddos are the ones that they have a huge gap. They're able to take steps even though when they turn 4, 7, 10. We have a client from Peru that he started to take independently steps when he turned 15 years of age.
Hmm.
And after that, he was able to walk 3 or 4 miles in a row. So that makes this kiddo, teenager right now, not just changing the way of he lives, right? But thinking
Yeah.
that having this approach in your pocket, right? Having this approach in your toolbox is like you have these key components, that alignment, that vision, and that clinical reasoning that helps for this kiddo to be late walkers. So when I always do a treatment, I always start from that, from NDT training, from NDT perspective. What my child has, what's the distribution, if he's a quad, if he's diplegic, if he's triplegic, if he has hemi, if he's attitoid, if he's dystonic, if he's a spastic, because it gives me different ranges where I still think, okay, this child can walk, or I had more chance or more challenges from the beginning, but still able to achieve some independence. So
Yes.
if we compare that to what evidence says nowadays, they say that a child doesn't change after 4 years of age. Like you have everything. If your child is not able to walk at 7 years of age, they're not gonna be walk independently ever in their life, and that's not true. From my background, from my experience, for where I'm come from, you can make this kiddos work even later, but you need to think and count about alignment, motor control, motor learning. That is very important for these kiddos in order to control their body, to control those reflexes.
Yeah.
My background as well. Little I knew that I was doing intensive therapy from the beginning, because where I'm from,
Yeah.
you do therapy every day. Monday
Oh,
to
do you?
Friday, you do at least one hour of PT,
Wow.
1 hour on OT, and 1 hour of speech. And we just knew that that was, or we thought that was just
That's,
regular therapy. So
yeah, that's
when I come to United States, that's that's intensive therapy. And I was like, wait a minute, I need to do once a week 30-minute session. What's this, like what's going on? Like I just have 30 minutes in a week to treat this kiddo. So little I knew that we were doing back in the day in Colombia
yeah.
intensive therapy, and some kiddos they even have 2 3 hours of physical therapy, 2 hours on OT, and 1 hour of speech. So you see this beautiful improvement with
Oh, yeah.
these kiddos that they look very impaired, that they look very low in their
Yeah.
function, but through that intensive model that we didn't know we were doing, because this is everybody does the same, everybody gets the same amount of hours of therapy. That's back
Yeah.
in 2000, early 2000s, 2010, 2012.
Do they
Um,
still get that?
that
And like,
that's where you see this.
who pays for it?
Nah,
Like it,
not
it's
anymore.
just
Unfortunately, unfortunately, they changed a little bit of the healthcare system. They try to copy more of the United States system. Less is more,
yeah,
and sometimes less is not more. And
yeah,
now they have less therapy, and now we see the changes in functional levels of these kiddos, because oh, now we have one session per week, and
yeah,
now I understand a lot about, okay, now why we don't see any progress is because it's
yeah.
very little therapy,
Yeah, I came from
very
a
little.
just a little background on me too of working in the US my whole career because I think we've been practicing around the I've been a little over 18 years for me, but always have done neurological rehab as well. But I came from a rehab hospital and we had an intensive day rehab program. So, but it was after acute stage illness, like injury. So brain injury, spinal cord injury. So I saw that too. I worked in an intensive model, but you had an hour of OT, hour PT, hour speech. So you transition from inpatient to that. And we even had like a amazing program, which was school. Like they do a school program in between. So the kids would be bused to the program. And then we did community outings and all that. So like you said, just like amazing progress that you saw real rapid. But typically in that acute stage, post brain injury after with a normally wired brain prior, you're going to see that rapidness. Well, that's what we were told, right? And that's what, when I first started, that was the norm. And then I remember then kids would go down to like 3 times a week, then 2 times, then one. Like we would do this progressive downturn, but really never discharge. And then it switched to the episodic care of 1 to 2 times a week for 12 weeks. And then you're just like done. And I remember definitely like a shift for me, but like I still worked in a day rehab program, but then a lot of times I would follow those kids through, and I always knew that I could do more, right? It was always like, I know if I saw them more, because it was like you saw this rapid gain, and then when they transitioned home, it was like slow. But I was like, okay, if they were, and I've always been heavy into, I've probably been doing STEM since the beginning of my career. And like, I've done a lot of these approaches that I really find effective in the intensive model. Um, but it was just told like, that's what you did. That's what insurance pays for. And then you really don't have a say because you're in the system, right? You're just at their beck and call. And I think for me, when I did my NDT training, I did it with Casey Hertz in Chicago, who's so amazing. She's actually a physical therapist, but very like functionally based. And I think I did it later in my career where I'm like, oh yeah, I already have like, I'm heavily trained in manual therapies and like no movement. Well, I'll do lots of STEM, very neuro. That's like all I've worked with, heavy on the vision. So I feel like I had all these tools. And then when I got trained in neural developmental treatment, it was like the light bulb went off because as an OT, I'm like everywhere because our scope of practice is so broad. So I'm like, I got to work on vision. I got to work on vestibular, all this. And I have a few times a week at an hour. So you're trying to hit it all. And like, you didn't really you saw change. You knew your stuff, but it was just like, I don't have enough time to like work. These systems need to be worked more to really create new motor pathways, right? So I remember my NDT training, as like you probably know too. It's like real extensive training. I think a lot of people don't understand. Like we would go 4 to 5 days every month, and then you're getting classroom instruction, hands-on instruction, then you're seeing patients, and then you're going back and you have homework, right? You have patients that you're working with, and then like you're doing the whole
Hmm.
process. So it's
Yes,
kind of like I always tell people it's a framework too, because no matter what, it depends on what tools you have, how effective and it's also you have to think. We can all be NDT trained, but we might use it differently, right? So I'm bringing all my tools
it's
and I
true.
do this, but the framework of it is analyzing what's going on with the child. Okay, what are their goals? What's inhibiting from their goal, right? And then say, and then how do I get them to that goal? Where am I going to start? So it's very complex. It's a very complex thought process. And then you're very in tune to the doing it the right way, right? Like elongating tight muscles, inhibiting spastic muscles. So you're looking at what's going on, inhibiting them from moving, and then you do a lot of repetitive movement in the right way with the right facilitation and inhibition, right? Um, and then I remember getting one of the kids I had was so low level. And in 3 days, I was like, he was doing stuff that I'm like, in 3 days, you're doing that? That's crazy. When I was doing the training, and to me, it was like the light bulb clicked on is like 3 days in a row with NDT, like with focus, like a focus goal. And I was like, okay, that makes sense. Because before I had the intensive, but my goals were not super focused because I was trying to hit all the goals in my little hour I personally had. Even in an intensive program, as a OT, I only had 1 hour a day. So I think fast forward to this intensive thing, and when I started my clinic too, I knew I would have an impact, but like you never really know because you've never had. I do 3 hours a day, and then when I have these kids come in, and I'm like, holy cow! For a 2 week period, like every kid that walks in the store, even after session one, you see it change, right? And I'm like, this is like gold. It's just amazing, right? And but unfortunately, we know insurance doesn't pay for it. But I So I love seeing you use the NDT approach and whatnot, because, and then we're seeing more function. I think that's the beauty of it, is like the functional component of it. Like I just, it's really, really, really cool. So
Yeah, I
very
just laugh when you say about the training because, oh my God, it's for adults. Back in the day, I took my NDT training in 2010. That was like a month and a half, back to back.
yeah,
Monday to Monday, doing therapy in the morning, in the afternoon, doing a lot of clinical reasoning, a lot of observation, a lot of why my client is looks like that, why they're moving like that. Even before you touch a patient, you need to think about why the patient looks like that, what happened to the patient, why
yeah,
without touching, you just think about, okay, this is the reason that your patient looks like that, or why they walk in this way, or why they have this problem of the shoulder. For the pediatrics training, it took like a 2 months training, and it was a lot too. And we have real patients that we need to train, and we need to show progression in those times. We have like a 2 or 3 clients, and depending on the type of CP, we need to know about the prognosis, the tone, how to facilitate depending on the tone, depending on the prognosis of the child, and the functional outcomes, and everything should be functional for the client and oriented in the parents' goals and the child's goals. So it was a lot, but it's something a training that I haven't done as extensive. I have taken other courses and training, but not as long as in detail as NDT training. NDT training is something that it's you really need to deep get
yeah,
deep knowledge of what you're doing and why you're doing it, and not even the first and the most important part is the clinical reasoning. It's like,
yeah.
just think about why your patient looks like that, what happened to
Mhm.
this client, what's the reason, and why he's not moving in a different way, why he's not looking more normal or more functional. Just from that, you need to start thinking and do a lot of clinical reasoning and think about what was the reason of that, and then you put your hands on your client and then, okay, oh, there's a restriction on the trunk, there is a restriction on the shoulder girdle, there's a restriction, oh, there is poor activation, there is poor movement of the scapula, oh, it's poor selective movement of the upper extremity, that's why my client looks like that. Oh, the hand is too tight. But then you see in a hemiplegic client, oh, but the lower extremity is not in a good placement, the foot is not in a good placement, the base of support is asymmetrical. It's a lot of effort, a lot of spasticity. So it's seeing the client as a unit, as a one person, but analyzing what happens to the head, it impacts to the toe. What happens to the toe impacts to the tone of the hand. So it's something that is a lot, because it's not a cookie cutter technique like you just do one exercise or you do a checklist. Okay, and then, okay, you did this exercise and this exercise and this
Yeah,
exercise, and then you're just
yeah,
gonna do like exercises that might not benefit the client. Versus here, you need to
yeah,
really know what's happening, you need to feel the body of your client, you need to know what's the restriction, you need to know the range of motion, you need to know the tone, you need to know the functional level of this arm or this leg. So
yeah,
it's really something that shaped my the way that I see things, the way that I
yeah,
treat clients, even though some clients are not neurological clients, you might say, like kids into the spectrum, autistic, ADHD, orthopedic clients and whatnot. I'm like, everything is entity. Like, okay, why you're having pain? You have
yeah,
poor pelvis movement, you have poor activation, you have
yeah,
poor motor control, poor motor learning. You're moving in a way that is injuring your body. So it's something
yeah,
that very I'm always, when people are, oh, what are you doing? I'm doing NDT plus. Always
yeah. NDT plus,
NDT
yeah,
plus. It's
yeah.
like
Because I always say,
NDT is part of what I do.
yeah, I always say
Even
that too.
though
'Cause
it's
it's
my
not,
hands are not there,
yeah, yeah.
but it's
NDT is
NDT at
like
the
that
end.
framework, but the ability to dive deep and have the skill level to dive deep and really know the body and movement, how what's happening. I always tell like students that I've had a lot of students, and I'm like, they're like, oh, I want to get trained in NDT. I'm like, wait several years and get your hands on kids and do mini courses. But if you get trained like that right off, a lot of times you have to have a few years before they'll even allow you in the course in the US. But I think like for me doing it when I did it, like I could be that much more effective because I could dive in deeper, right? Because you had all these other things and you understood movement, you understood, you felt tone, you've worked with tone, you've handled children because there's so much handling involved. And if you don't know what's going on, you're not going to practice it effectively either, right? And just having, like, I know you and I both throw in, okay, I'm going to add in, I can tell they don't have good body awareness or they don't know how to, they don't even know where this muscle's at. They can't fire it because they've been using tone. A lot of these kids use spasticity and tonal patterns to move, and they've been doing that. Like, and then there's the whole like people do reflex integration, and then they're like, "Do you do that?" And I was like, I mean, I do in a different way because I block kids from using reflexes to move. And then I facilitate muscles that I know they need to find in order to move, and then I make them move the right way, right? And it's a lot on your body initially, but the beautiful change I see in kids and like the difference, but you have to do it in an intense level. And a lot of times in between intensives, I'll send them home with, okay, you're going to tape them this way, you're going to do this stim pattern, and I want you every day we're doing that. And then give, parents some simple things to work on. So when they come for their next intensive, we're like ready to go. And a lot of times if they follow through with that, it's like it's a process. It's a lot of work. But I think, that ability to do that, you actually see the brain change. And I had one of my patients come in and she had a global anoxic brain injury, right? Today. And we did an intensive. She's done several. Um, and she's done different techniques and been to different places. And but it was cool because we did like we finished a week intensive about like 2 weeks ago or a week ago. So she had a week and then she came in today, and it was like she came in just to do some stuff with me, and I was like so cool. She's like, you can tell she's activating the muscle. You can like her muscle tone has changed. Like she's actually activating the right thing. It's almost like that normal, you almost like feel normal muscle tone and not like she's just trying to fix and whatnot. And she's finding muscles, she's activating. It's a lot quicker where she's figuring out how to counterbalance herself. And I was like, that right there with nothing on, no stim or anything to help her even more. That's that new motor mapping. Like she's got that motor mapping now and she's got that awareness, and like it's the coolest thing. And I don't think until I opened this intensive clinic and really got to work with kids that way to just, and I get a lot of repeat children and you just see this progression. And I was like, I honestly can see in 2 weeks what I would see in 2 years working in a traditional model. And then to see this like within a year, what, kids change if they do, the right treatment. It's just mind boggling. Actually, it's like, I've been like, that really happened. But like, you get to, it's not that you didn't think that, but you get to actually experience it now. And we've,
Yeah.
luckily, I think not luckily, because a lot of people can't access it because of lack of insurance coverage. But being in Florida, we have a lot of our kids have step up. So that helps it become more
It's a
accessible.
blessing.
It's a blessing for sure. But just like, yeah, it's a huge blessing. But just, I think it just, I think us that do the intensives and stuff and seeing all this change, like you hope for every kid that eventually we can get insurances to like recognize the benefit of this. I know like in Australia, they pay for 3 intensives a year or whatnot. And then it's interesting to hear that like where you're from,
Wow.
that was just a thing, and now I'm like, yes, we have it, but I've worked in the intensive therapy, but it's different, right? It's not. And then who doesn't? Where I worked, it wasn't the kids at CP that got that, unless they had like a SDR surgery or some sort of surgical intervention that required intensive therapy after. But even that was like, okay, after 60 days, you're done, or 60 visits.
Mhm.
So just super, super, super cool. And like you said, just you wish more people could get trained like that and think like that, and every kid could get all this intensive, really good stuff that we are seeing changes with. But unfortunately, that's the barrier we have in this country, right? So, and just even, I think even newer therapists, there's the mentoring is so different now. I don't think, the bigger hospitals they don't have like, they're not putting as much into their employees. So like I was able, luckily enough, to get trained and my job paid for it, right? So it's a big expense and a big time commitment. So we did the 8 month training, 4 to 5 days, because we were still kind of working at the clinic. And then you had your homework. So you did more like the fast track, right? Like let's just take
Yeah.
this amount of time and you just get that full training. But yeah, I think it's just, it's such an amazing thing if you can do it as a therapist, right? So
Yeah, it's every time that I have clients and you might have the same experience. Um, I use a lot of my hands, my handling skills.
mhm.
I have a kiddo with right hemiplegia with a functional scoliosis, very poor function of his impaired hand, very spastic, very asymmetrical. And the mom was like, I was using my hands on his trunk. I was just firing the muscles, put the nice alignment in order to activate the muscle. I was just working there. I put different toys. The parents helped me with the toys. Okay, we're gonna reach here. We're gonna reach there. And I was always, my hands were always at the trunk or always facilitating the arm. And I was telling the man, okay, now he's gonna walk in this way. And the mom was like, how if you haven't practiced walking? I'm like, because I'm preparing him for that. I don't need to
Yeah,
work on gait in order to improve the gait. If I have the base of support, if I have the alignment, if I have the activation, the preparation for that, I know he's gonna do better at that. He doesn't
yeah,
need to practice that in order to get better, because a lot of times, and it's happening lately, that oh, the more that you do it, the better that you get. But if you don't have alignment, the more that you
yeah,
do it, the worse that you get to do it, and the faster that you get to do it in poor alignment. That's two different things: to do it
yeah,
faster but badly, or to do it better in alignment that is gonna be for life. I always say, I'm gonna prepare your child in order to maintain this alignment, in order to function from now to the end of the days. I'm gonna prepare
yeah,
this body to learn how to move functional and not having pain, chronic pain, because this is a big issue now that we have with our kiddos, that they move the way that they can move using assistive
yeah,
technology devices, or they go through different approaches that what I care is they move. It doesn't matter how they move, but at the end they lose their function. They lose that pseudo function that I call it. Like, we know that in a few years that child is gonna stop walking, gonna stop using
yeah,
the walker, because it started from poor alignment, from poor functional patterns, from faulty patterns that at the end is gonna impact more negatively in those kiddos versus function. So I always say, I always go for the long run. I'm gonna
yeah,
prepare this little human being in order to walk independently now and learn the good way in order to maintain the good way from now on. So the mom
yeah,
was like, and then she saw the kiddo walking very nicely, and she was like, "Oh, but you didn't even practice gait." I'm like, "I didn't need to. I was
yeah,
working in these muscles, in this activation. They need to." And a lot of things people skip is about the sensory part of things, right?
mhm,
That OTs are very huge, hopefully, on
yeah,
that. And
yeah,
physical therapy is not a second nature for a lot of physical
yeah,
therapists, the
yeah,
sensory part of movement, right? And I'm like, if you don't feel it, you don't activate it. If you don't feel it, you're not aware of it.
oh,
If you don't feel it, you don't have a good pattern. He needs to feel where the muscle is. He needs to activate
yeah,
this muscle and to pair this muscle with this other muscle and this other muscle. And then I was telling the mom,
yeah.
oh, he's not able to reach the arm. Let me show you. And then I show, I
He
did my
doesn't know.
facilitation
Yeah,
and put the muscles where they were, where they should be, and then
yeah.
he was lifting the arm like nobody. And she
Oh
was
yeah,
like, but how come? I'm like, it's a kinetic change muscle. It's alignment. He needs to
yeah,
learn how to activate this beauty
yeah,
right here. And while I was doing that, I was fixing the scoliosis as well. So she was like, "How come nobody does this to my child? Nobody tell me he has a scoliosis. Nobody tell me. They say, oh, he looks fine because he's walking, and you tell me A, B, C,
Yeah.
and D problems, and then you're fixing the problems right there in there." And I was
Yeah.
like, "Well, I don't know. I'm NDT, I guess. That's my short answer
Yeah.
for
I
those
think it's
times."
just you value that, right? Like I really value because I think that too. I also think like where is this going to go? So if you let a kid walk a certain way, like cool, that's like you said that too, but if you're actually developing muscle awareness and alignment, you're reducing injury, reducing pain. And then when you go to that next motor skill, once they achieve something and you have alignment and the kids know where their muscles are, that next motor skill is going to be that much easier. And I see that, right? And I value that and I know that. And then it's like, and I know the brain part of it too. We don't, I think it's a time thing. Like a lot of therapists are restricted. So, you got to get them functional. You got to get them as independent as possible. So it's a mindset of like us as therapists, we all practice different, think different, whatnot. We have different tools, but I think I've always valued that too. Like now, especially now that I can, so when people come to me, I always say, you know what, a lot of the kids do other therapy and they'll still walk on their walker and whatnot. So when they come to me, I have intensive therapy and I say, I let them know before, like, I'm working on quality of movement, finding muscles, building lots of reps with motor pathways, but we're going to move the right way. I'm going to block your kid from using reflexes. So same thing sensory wise, I load kids up with all the input like I do. You'll see some of my kids and they look like a zombie because they have like neomobilized,
Avatar. I
like,
say Avatar.
yeah, like kinesio tape, like E-stim,
I love
spinal
it.
stim,
I love it.
like, and then, and I'm big on like having them find stability because as an OTT, I'm like, okay, if they can hold on to something and reach and work on disassociating movement, that also in weight shift and whatnot, that carries over into their PT, their walking and their mobility as well. And then also if they can hold on and pull their pants up or they can, so I think it's such a huge thing. But even by the end of a 2 week intensive, I do pull it away. And then I'll say, okay, well, now we're going to keep it on one side. And then I'm going to give the other side and we're going to work on the one arm, moving away from the body. Because a lot of these kids move their whole body. They move their arm and their whole body goes and they lose their balance and you got to get them to engage in something functional. And that's never going to happen if then we're like, okay, here, there, that's cool. Or like you said, they can hold on to a walker walk, but then what else can they do? Right. So I'm big on those types of things as well. But yeah, it's just kind of, I think you and I probably have the time to do that. I think that's just how we think and that's how we work and we get really good results. And I love too knowing that kid, because like you said, a lot of kids have a scoliosis or develop. Most of our kids with neuromuscular disorders have some sort of scoliosis or whatnot. So if that keeps prolonging, these kids end up having surgery. They have a lot of health issues. There's just so many things that can go wrong, or their scapulas are winging out. And then a lot of times I have parents like, do this and try to tell, they're like, oh, they lift their head. I'm like, but they're here. How, you try to lift your head
Hmm.
when you're here. So I always like really
It's
accentuate
too
like getting
heavy.
them in positions and be like, oh, if you do this, isn't it crazy how all they have to do now, you give them stability here and proper alignment and positioning, and they can activate the muscle the way we want them to. And then we have to help them find it because they don't feel the muscle like, especially a lot of the kids with CP where they're born with a kind of a unwired system, not like everything's flowing like it should, and they're not getting the feedback because they're not moving like typical developing children do. um, we have to create all that for them, right? And some of these kids come to us 2, 3 years in and they really haven't had any of that intervention. So how do you expect them to just know where their muscle is, right? And then the vestibular system and the vision, like that's also ties so much into how we know our bodies in space. Some of these kids have never moved back. Like I do a lot of movement backwards, sideways. Um, we do rotary and we do rotation and stuff, and that's so important too, like you can't, it's huge. So I have one kid with quadriplegic CP that I've been working with for a while too, and we do a lot of backwards, And we walked stairs like crazy for a lot of reasons, and him holding on, moving away, and just we get lots of reps and feedback and whatnot. So, and getting him to just activate his postural muscles better and stuff, whatnot. So it was so cool because he recently mastered going upstairs independently by himself, and then he's like has this confidence now, and now he's like he wanted to go backwards, and he's like I'm sitting there like, oh my gosh, you're gonna fall, and I'm like, we've never even practiced that. But we practiced backward movement in a lot of other things, even in a little kid car. Like we do backwards a lot. So he gets to find balance and activation of that balance of the muscles. So I was like, that's like the aha moment of why you need to work kids and work all their systems and bring that into practice, right? Like you said, don't just get them walking, but let's give them more. Let's give them more feedback and all these systems that we know we need to be able to function and hold our body in space and whatnot. So,
Yeah, that's amazing. I always say when and the same happens, like parents have, they don't know what to do and they're trying their best for the kiddos. But I always say to
mhm,
the parents, ask your therapist about their experience with your a kid that looks like your child, a kid that has
yeah,
kind of the same function as your child, and see what they can show you with their experience. Because a lot of times, and that's something that very I always talk about, is like not every approach is for every child, not every exercise is for every child, and parents should know what's the prognosis of the child, depending of the age, depending of the tone, depending on the CP, depending on the diagnosis. But at the same time, as for your therapist, what have you done in those cases? Because a lot of times parents, they do therapy and they do a checklist of exercises, and the same exercise is for every child, and that's unfortunate, and that's not what your child needs. I always say that your child has unique alignment and unique needs, so it cannot be
yeah,
treated as a cookie cutter approach and as a
mhm,
checklist of exercises. Your child has different challenges depending on the tone, depending on the injury, the area of the brain. So ask your therapist more about a kid that looks like my child. What have you done to a child like that? Because a lot of
yeah,
times it's like, okay, I'm gonna do this exercise and that and that and that, but what have you done? Show me your results. So you're
yeah,
saying you have a quad doing the stairs is like
yeah.
huge for
Oh, it's
whoever
huge.
is will
Yeah,
listen to this podcast. A quad doing the stairs, climbing the stairs, that's like huge level
yeah.
of course of the child improvement, but of the skill of the therapist, that is Jenny. Having
Oh,
a quad doing the
yeah,
stairs, it's
yeah,
huge. And I always say
yeah,
to the parents, like, I have, and I talk from my experience. Oh, my child is quad. Yes, I have kids with quadriplegia that they're able to take steps, that they're able to
yeah,
walk with crutches, that they're able to walk with a walker. Even though you're quad, you are
yeah,
able to get to that level. But depending on your age, depending on your tone, depending on your medical history, not every quad is the same. So I always ask the parent, like, ask your therapist. Don't be afraid to ask for other experiences, for other families, and to know more the reality of your child. Because I always try to keep my parents grounded. They're free
mhm,
grounded, but their minds on the sky. Like, we're grounded. This is what he has, but we're gonna reach the stars. But we're gonna keep
yeah,
it grounded. We
yeah,
know what we're doing right now, but I know if we get this, we will be able
mhm,
to get to that point. And I think you might have encountered that a lot of times. Like, okay, my child is not walking, but you check that child, and it's something that I call the functional child, but it's not functional child. And I have seen
yeah,
a lot lately is that the child that is able to crawl, not good pattern, but crawling, pull to
mhm,
stand, not good, but pull to stand, and
yeah,
cruising, but not able to walk independently. Very poor planning, very poor control, very poor motor learning. But then you set this child on the floor and they don't have fine motor skills. They're not able to use their hands. They don't not able to have good sitting skills.
Mhm.
They're not able to move out of sitting. But how come a
Yeah.
child is so functional, but at the same time is not functional at all? So I always say, like,
Yeah.
if you skip sitting, if you don't free your hands, you're not gonna free your legs from a walker. So
Yeah.
it's everything is connected. You can
It
overuse muscles that are not for that function and still look functional. But when you
Mhm.
really aim for those muscles that are the postural muscles and good motor planning and motor control, you're gonna be able to be more independent. So lately I have those
Mhm.
cases that okay, my child has been doing cruising, this and that, and still not walking, and they put it on the floor. Falling all the time. Oh, they're not able to use their hands. Oh, I'm not surprised why the child is not walking. A lot of people think, and I was saying before, doing more sometimes is not doing better. And practicing a
Yeah.
skill sometimes is not something that is going to help you to aim that skill. Like practicing more steps is not going to help you to walk. Practicing walking with a walker is not going to help you to walk independently if you don't start from a good motor control, motor planning, and alignment. So I would say I'm working on this sitting. It doesn't look fancy. It doesn't look like I'm doing a lot, but after that, your child is going to be able to sit to stand, cruise, and take a
Mhm.
step. And they're like, how come? And then, NDT hands, and they, oh,
Yeah.
they're taking a step, but you were just doing sitting. I'm like, yes, because they need to fire these muscles right here that is easier
Mhm.
for them. If they
Yeah.
fire and know what to fire and when, they're gonna bring that knowledge to that standing and to that gait. And they're like, oh, now they're walking finally. I'm like, well, they were missing the muscles. They were functional, but not functional at all. Like,
Yeah.
you can be functional, like you can move, but with poor planning. But in order to be a skillful and
Yeah.
to aim something like a independent gait patterns, you do very good at motor planning, like very, very, very good. In order
Mhm.
for you to have hand function, you need to be very good at your trunk control and your pelvis. So
Yeah.
I think it's it's a lot. Like a child is able to pull to stand cruise, but not able to play with their hands. Can you imagine as an OT, a child that is not able to play with their hands in sitting
Yeah.
because they're so
Yeah.
busy trying to keep their balance that their hands are not free to
Yeah.
manipulate. And
They're
that's
kind of like
I always say like don't
stabilizing. Yeah.
yeah. Some parents
And
like
the minute
oh
you take
gait. I'm
away
like
from
yeah
them, they collapse. Yeah. And I always
yes.
say that too. Like
And
this
the
is
gait is important.
a lot of
But
kids
hands are
can't walk.
important too. Don't forget the
Yeah.
hands. Like hands are very important.
Yeah.
Gait is just something that everybody aims. But don't forget the hands. The hands is what
Yeah.
make us humans.
Yeah. And I
Like function
appreciate you.
ADLS. I always say
Yeah.
ADLS.
Yeah. And I think like that's a big thing. I really appreciate when PTs pull in the hands because I'm like, I think I work on the whole body too, right? Because you have the skill to do it, and you know how to facilitate, and you have the training to do it. But it's like I am big on hands. Like you'll see a lot of me having kids hold on, and I don't have them hold here where they're like using their reflexes. No, I'm like,
The
okay, I need
phone.
to lengthen this. I need to get this up, and I'm going to put them out here. And then they start to get all this. They start to activate all this. They have that stability, but we want that's the stability we want when we do functional standing tasks and walking and whatnot. If we have stability here, like you said, the minute this arm goes, the whole body's going to go because that's not really the right postural muscles they're not really activated. They're stabilizing against here, and that's how we have the arm here, right? So when people look at that movement, a lot of times we let kids move that way, and then we wonder, or they don't have their protective reactions because they're so busy standing up and they've never really been able to practice that. But even when you get that postural control, and I do a lot where I have kids grasp, and I will tell you these are the kids that are really really tight and you can't get them out. So like we'll inhibit a little bit, but then I inhibit them, and then I give them stability and I have them work on true. A lot of times I'll just strap their hand on it and they're working on true intrinsic activation. And a lot of times I'll start to see them after even just a basic grasp activity. Now it's functional. And then you actually start to see that hand change a little bit of like they're finding muscle here and they start to play around with it. And I mean, there's a whole complexity in that too. But some people are like, oh, you don't do as much fine. Well, I mean, I do, but like some of those kids, I start here, great gross grasp and finding muscle. And I take away all that really strong spastic pattern that they love to use, like kids love to use, and they're not using the true muscle. They're using that tight, that tone, that tightness, right, to stay up. And I think that's something that, it takes a lot to rewire and like re-educate the brain with a lot of different tools, and it takes time for that too, but it does work, right? So I think that's the one thing, and
It's
I think
amazing.
that's why
One thing that when I find your page, your Instagram, and I saw what you were doing, and I said she's
oh
an OT, but then I was looking at it like let me see what
yeah,
she
no,
does,
she's an
and then
OT.
oh, but she's able to do sit to stand very nicely, and then I was like oh, but she facilitates very nicely, and oh,
Yeah.
like she's doing very nice gait patterns. I'm like huh, she should be
Oh
NDT. I was
yeah.
like I know what you're doing.
People, like ask me questions like, "You're like a OT?" I was like, "Yeah," and I'm doing OT stuff. It just looks, like for me, like you think about it, and I think a lot of it's my background and where I worked, because you work with a kid coming out of a coma and an inpatient, and you're doing transfers, right? So like I've always done handling and standing and moving and whatnot, and then I, did a lot of the day rehab. So like I've worked with a lot of brain injuries, spinal cord injuries, stroke, and those types of things. So it's just like I wasn't a fan of like, okay, I'm just going to keep a kid in a chair and have him do fine motor, because I knew I had more skill level than that, right? And so, and I also had the patients. I had a lot of tough things that I saw because I worked at a primarily like trauma center, so that's majority of what I saw, and I would see kids with a brain injury and an amputated leg and a, partial spinal cord. I mean, you would just get these crazy off the wall stuff. So as much as I could, I had great mentorship, and I did all the training I could find, and all the tools I could find, because all the kids I saw needed all the tools. And I even did some feeding and swallow studies and whatnot. But it's a beautiful thing, because then when I did the NDT training too, you get globally trained. Like have these people come in, but I was like, okay, cool, I've been doing that. So for me, it's just been how I practiced pretty much my whole career. I don't think I've ever just had a kid sit and do fine motor, and you see the whole picture because you had to, right? And then you had a lot of
Yeah,
practice. You had a lot of kids. I mean, you're seeing in that setting, you're seeing like 9 kids a day, sometimes. So, and then
yeah,
I had amazing therapists to learn from, from the start of my career. So and I was like early trained in a lot of manual therapies, which you get to know movement and body and asymmetries and whatnot real early when you get all your manual training. And we utilize that a lot at a lot of the physiatrists that I worked with wanted us to use that in our practice as well. So that's why, yeah, too. But I think I get a lot of people question that and like kind of, why are you doing this? Why are you doing that? And I was like, the way I look at it is probably a little different than a PT looks at it too, but depending on a PT, because think you globally look at it too. And I love that you do constraint for the arm, because you're looking at it in a different way. And it's a tool that I think, and I know there's other PTs that pull that in, and I'm like, that's amazing, because why are we why are we separating things if we have the tools and the skill level, but we probably have a different, my goal at the end of the day is probably a little different than what your written goal is, right? My goal is for them to be able, it's probably thinking of it differently, but you got to do all the same techniques to get the child there, right? So,
yeah.
but yeah,
That is true, and that's the beauty of NDT. When we did the training, you the instructor, it was a speech, OT, and PT,
yeah,
but they
yeah,
could do everything from feeding,
yeah,
breathing, fine motor skills, gait, crawling, like even the speech was able to do the
yeah,
whole thing. Even the OT was able to do gait facilitation. Even the PT was able to help with ADLS. So that's the beauty of being trained by NDT, because you had a very broad knowledge of everything.
yeah,
You seeing a human as a human being, and not just this is the legs are mine, the arms is the OT
yeah,
problem, and the mouth is the speech problem. No, it's a human being that we can intervene and help. So a lot of
yeah,
kiddos, and the mom is like, "But you're a physical therapist." I'm like, "Yes, but I'm
yeah,
NDT." So I even
yeah,
teach the parents how to clean their kiddos' faces just to give more stimuli for that face, to
Yeah.
be aware of that saliva. For kids
Right.
that have any impairment with the hands, I always use not just CIMT, but using other tools like an NDT. Just okay, I need these hands because if he's not
Yeah.
skillful with the hands, doesn't have a good grip, a good grasp, he's not gonna hold on to the walker. That's my goal. My goal is
Yeah.
to hold on to the walker to be able to pull to a stand for my gross motor skill.
Yeah.
That's what I'm aiming for. But I need something to pull from, so I need to strengthen these arms. I need to strengthen the shoulder for my gross motor skill. It's the same
Yeah.
like you, like you're
Yeah.
OT, but you work on crawling, you work on pull to stand, you work on transfers because of ADLS, how to dress, undress, how to move from point A to point B. That's an
Mhm.
ADLS. So that's the
Yeah.
beauty of being trained in NDT because you need to see the human being, the person, and the
Yeah.
function that you need to work on as a
Well, it's all connected
together
too.
and as an entire body,
Yeah.
and as like okay, this is just my part because
Yeah.
a lot of issues, and to be honest, if you're not breathing, you're not able to swallow well. If you're not have a nice sitting control, you don't have fine motor skills. If you don't have a
Yeah.
good trunk control, you don't have transfers. You don't have
Hmm.
standing balance. You don't have gait.
Yeah.
So it's everything interconnected, and we see it as an entire body. It's not that this
Yeah.
is your
Totally.
part and this is my part. And it's like I'm helping this human being, but then
Yes.
and it's good like in your case like you work in a intensive model with another
Yeah.
therapist. I'm preparing my client. I'm working on gross motor, but I'm preparing this trunk for the fine motor skill that is going to come next.
Yeah.
Or
Yeah.
you as an OT, you're working on arms and I'm working on transfer because then the PT is gonna work on gait. So it's everything is interconnected and everything is smooth. It's like it makes sense to the client. It makes sense to
Yeah.
the client for that motor learning because we're connecting repetition, motor learning with function. Like it makes sense to them
Yeah.
in real life. And I think that's
Yeah.
something that unfortunately is not a trend and it's not
Yeah.
happening lately. Like a lot of like, okay, I'm just the arm, I'm just the leg, I'm just the eye, I'm just the mouth. But at the
Yeah.
end, you need to know more than just that in order to help that
Yeah.
person, that client that has disability. So I think because when I saw the video, I'm like, oh no, I need to reach out to Jenny because I'm sure I was like, I'm sure she's NDT. That facilitation right there, that improvement there. And I think I saw a kiddo, the one that you mentioned, the quad, and I was like, and then you show, right, the days.
Yeah.
5 days later. And I'm like, okay, I'm not surprised she's NDT. 10 days later, okay, yes.
Yeah.
15 days later, and then this kid was walking. I'm like, of course. And I was like, she's an OT. And then I was with somebody and I said, she's an OT, that she is a PT and I can send
Yeah.
anything if I know and is in her area because I know she will do an amazing job. And I have sent
Oh.
some clients that I know that is in your area, like please go to Jenny. You will
Oh yeah.
get an amazing therapist that
Yeah.
you will be very
Yeah.
pleased to have her
Yeah.
as your care as your therapist. And I always say go to if you're in Tampa area, if you're closer to Tampa area, go to Jenny. Like she's an
Yeah.
OT, but she's an amazing OT. Like you
Yeah.
don't really. I'm sorry if I say that. You don't need a PT when you have Jenny. Jenny
Oh,
has
well, thank
everything.
you. Yeah. You're doing an amazing job.
Like you're missing the dynamic place cast thing. Just
Yeah.
that.
Yeah.
But you're amazing. I'm always checking your Instagram. Like, oh my God, what's new with Jenny? Let me see
Oh yes.
what's she gonna
Yeah.
bring to
I
the
always
table
have something
this
new to
time.
chat about. Well, and I think the same with you too, because I think I just love seeing your work too. And like, yeah, you like, because I think we practice so much alike. So I love seeing that. And it's like, I appreciate how all these other things that people do too, but like when you find someone that practices you, like you, and you just know what you see and the change you see. And I think for me being in an OT, one of my biggest like things right now is I want more OTs to practice like this, right? Like I get a lot of times people will message me and say, oh, I want to, that's like the kind of OT I want to do. Okay, but why are, the training, why aren't we, I think like I've had a lot of students, so I start training them and getting them to think this way. And I always had the neuro population, right? So sometimes I think the disconnect too is a lot of OTs are not working in neuro rehab. They don't get the chance to. And then if they are in neuro rehab, they're not working with a pediatric patient. So there's so much, it's such a small area that you can find a job. And then I feel like people like me that once you get a job in that area, which I got one real early in my career, you stay there because you love it, right? Like it's not for everybody. It's tough work.
Yes,
It's well,
ma'am.
like you said, you got to think out the side of the box more. It's a lot of like, and that's what I love. Like I love out of the box thinking and like this and that and being able to pull in all this stuff like, and you just know what a difference you can make because these kids are more complex. But not everybody wants to do it. And then also, they don't get the chance to, right? So then you get further down your road in the career, and then you're like, I mean, I'm never going to learn that, but I think we need to get more OTs just even thinking this way. And like, if we start training them earlier, like I did some adjunct stuff through Western for a little over 10 years. And at the end of that, I did, they had like an advanced clinical practice thing, and I would just go in for just like a module. I didn't teach the whole course or anything. And I remember I did more of the neuro-based stuff. So I remember going in there talking about pediatric stroke and pediatric brain injury, and then I did like amputee as well. And I would teach them neural rehab stuff, and they're like, "Oh, this is great!" And they were like, like kind of in their level ones of like just like kinesiotaping, inhibition, and like it's like I remember that in OT. You hear about it, but you don't like how do I do it? And then like just even showing them and like letting them feel it and do it. And then they're like, oh, I'm going to go use this with my stroke patient. Cause they have like the little clinics. And I'm like, why aren't we doing this more? Because think about, like you said, even kids with autism and sensory processing disorder, those kids with the NDT approach kill it because there's more going on. Like a lot of them come in and they have motor issues. It's not just regulation. It's not just oh, they're sensory. What does that mean? Like they have poor body awareness, not, but they're all different. Just like a cerebral palsy kid is different, right? So it's yeah, a kid with autism comes in, and I just had someone recently like there. It was he was a toe walker, and obviously it changed his body mechanics, and then they kept casting him, but like and then at the end he was worse, and it was like because that wasn't his issue. The toe walking, he didn't have tight heel cords actually. He just was. It was a sensory thing, but for some reason people just want to keep casting him. And then a lot of it was like he couldn't. And then afterwards, it really threw him off because the issue is he didn't know where his body was in space. He didn't know how to activate muscles. So even after I evaluated him and gave him like literally 30 minutes of lots of feedback intervention, and he was already in some alignment with Koban, and he was walking up the stairs. Like the kid couldn't walk up the stairs before he came in, and I'm like, that's not like I'm not a miracle worker. That's just knowing that child and giving them. I gave feedback, and I remember the grandma was like just cry. She's like crying. She's like, "Oh my gosh, I feel we've been dealing with
Oh,
this for so long," and they kept putting him in a cast, and I didn't think it was right. And then they didn't do much intervention after. And the intervention he needed was just he wasn't getting, so he actually got worse, right? And they kept doing the same thing. I'm like, if it wasn't working, so I think knowing looking at the whole child like that framework. And I feel like as therapists we should already, even coming out of school, you should be able to like clinically reason what's going on with the child. You might not be great at it yet, but like looking at all the systems and whatnot and like why are they having that issue, right? But I think like you said too, I think some people the training that some people are getting now, it's like it's almost like a protocol, like oh, you do this, you do this, you do this. And that's such a disservice to our kids because majority of children need more than just you do this, then you go to this, you go to this. It's not super highly effective, right? So, but I know. I feel like we
that
could talk
that
forever.
that
So
is true. I'm
I
like,
I
yeah,
feel like we should do another
yeah. You
podcast
can
for
be
sure. Like
functional
I think
and
there's
not be
so much we could
functional.
dive into. But real quick, just to end, because I think, I think we're going on like an hour. So I just want the one thing I really wanted you also that like I would love for you to just like touch base on and then we can kind of wrap it up, and then hopefully we can do another time where we talk about some of
Yeah,
more in-depth stuff
tomorrow.
or more centralized stuff, because I think we have a lot to share with people that I think, my goal with doing this podcast too is just to like start talking about stuff and get information out there so parents can be real well informed about different interventions. I know it's like right now we're in that era of like you do a laser, and not saying that you don't get, reproduction and stuff, but they're like, oh, and then my kid's going to just walk, so there's a lot of this, like all this stuff out there. And it's just like, let's dive in deep into how the brain learns, how this works. This will do this, but you need to do this. And I think at the end of the day, I always tell parents like all these tools are great and they're all wonderful, and we're seeing brains like thriving and neuroplasticity is real, but you cannot just do one thing and not move the body and not reteach the brain and not give the brain feedback and expect your kid to walk. Like, just, if you just put a laser on a kid's head, they're not just going to start walking. You have to do intervention. It's like there's those types of things. So I think I would love to dive deep into like all the tools, because I know you and I always say there's a lot of tools, and if I only did one of my tools, I wouldn't get kids to where I can get them, right? And I know that. Like, and a lot of my kids get stem cells, they get laser, they do all that. It's all intricate in their recovery and then, moving better. But at the end of the day, you still got to do your reps, right? Like that, the only way you can really make new connections is moving the body. And that's how we learn as typical developing individuals. If we didn't move, we would never learn to move, right? If you didn't do an action, your brain wouldn't even ever do that, right? You have to get feedback. So, but anyway, so we can kind of go into just real quick, um, just your dynamic flex casting. So that's something I think I've been super impressed with your results, and I wish I could do it because it's like so cool. And it's like I love that alignment at the foot and the activation of the foot. Like I can do so much, and I know that OTs can't be trained in it. So luckily, hopefully, Diego's going to be coming here at some point. We got to find a date, but I would love a lot of my patients to get the flex casting. But I would like you to just tell me a little bit more about what dynamic flex casting is, and like the results you've seen from it, and in the changes that you've seen.
Yes, so thinking, going back to the reflexes and laser, and this is something that I compare that with dynamic flex cast. I have a mom that she's a therapist, and she's very heavy on laser, reflexes integration, and diet. Um, and she came to me, right? One day she saw one of my Instagram posts, and she was like, "Where are you located? Like, I need you." And I was like, "Okay, I'm here in Orlando." And then she showed me her child, right? And she was telling me, "Okay, he has pronation, he has this, he has that, he has seizure disorders." And I've been working, because she's a therapist, on strengthening and laser and reflexes and whatnot, and I don't see any progression. And then I asked, okay, show me how he does the exercises. And she showed me, and I was like, well, he's, even though he does his best, he's not having alignment at all.
Yeah.
And if you don't have alignment, no matter what reflex you're trying to integrate, or what laser you
Mm-hmm.
put in your child's head, or the diet, I'm not saying that it doesn't help,
Mm-hmm.
right? It might help in different ways, right? Because I'm a very advocate about nutrition, and that's something
Yeah.
that I have experienced personally about nutrition. I have ADHD, and I know how eating carbs a lot changed my brain dynamic. How if I eat more protein, it helps me better with the impulsivity. How maintain my um, to drink the water keeps me more at ease versus if I'm dehydrated and kind of going rounds and rounds in my brain. So I know from a personal experience how diet changed my brain dynamic having ADHD. So I see and understand out of what she does, and she does amazing with diets. But I was telling her, but he doesn't have alignment. So if you don't have alignment, no matter how many repetitions you do,
Mm-hmm.
you don't get the strengthening that you need. And he has poor alignment, and that starts from the foot. He has severe pronation, he has tight heel cords, he has severe misalignment. He has poor posture that start from the foot. So no matter what you do, no matter if you put on braces, no matter if you put an SMO, it still continues that poor alignment right there, and
Mm.
you don't get that any muscle activation that you're expecting, if, despite she's doing therapy every single day with this child.
Yeah.
Long story short, we did the first dynamic flex cast, and this kiddo, oh my god, from just putting the cast, he was upright, he has better alignment, his pelvis was more neutral, he was breathing better, he was walking even better because he had a huge base of support because of the poor
Yeah.
balance that he had. And she was like, "What do you do?" I'm like, "I just put everything in place. I
Yeah.
put the bones on the foot in alignment, so now he's stable, so now he can be upright. Now he looks better. Now we can activate the muscles." So I just showed them how he looked from standing, no casting at all, just what he had, shoes and barefooted. And then I cast him and I put him back. I said, "Oh, now you have muscle. The muscle was there, but you were missing the alignment. You,
Yeah.
despite doing the exercises, you were not targeting those muscles because of that poor alignment." And she was like, "Oh my god, I've been doing reflexes diet and this and that, and a machine that does electrical stimulation and whatnot, but not
Mm.
this huge result in just one session." And now since then she's a
Yeah.
huge client of mine, and she sent me like 5 clients of hers. And I was like, okay, I'm happy to
Yeah.
help everybody, whoever has misalignment. So that was kind of like how I can compare the new dynamics and the new treatments versus
Yeah.
dynamic flex cast, or how dynamic flex can help you. Dynamic flex cast is a creation of a therapist that I know personally. Her name is Maria Teresa Ferrer. She's the creator of dynamic flex cast. We are very few therapists training dynamic flex cast at the moment. It takes a lot of analysis, a lot of anatomy, a lot of knowing what you're doing and how to
Mm-hmm.
place the bones in a right alignment. It's not
Mm-hmm.
something that is a cookie cutter approach, and it's not something that I'm gonna do the cast in every child the same way. We were discussing before we have this podcast how knowing the child needs a misalignment, I can do one cast very different from the other kiddo. So if a child
Mm-hmm.
has pronation plus knee hyperextension, that cast will look very different from somebody that just have pronation of the foot. It's going to look very different from a child that has toe walking and is spastic. It's going to look very different from a child that is a toe worker but is more from the sensory part, ADHD, ASD situation, right? So
Mm-hmm.
dynamic flex cast starts from the alignment, how to place bone to bone in a good biomechanical alignment. So in that way, we're aiming for the child not to use braces. That's our goal, to improve the alignment of the foot in order for the child to be able to look more functional, to be able to strengthen the muscles that they need to strengthen in a proper pattern of movement,
Mm-hmm.
and no need to rely on braces. Unfortunately, a lot of kiddos on braces, they look bad. They don't have a proper alignment. Some moms, what they always say is like, "Oh my God, my child, I see the pronation is getting worse and worse and worse and worse. My child's leg looks smaller and smaller and smaller, or every time I go to the buttocks just stays there for a few months, or they have the rebound effect that is not even helping at all. What else can I do?" So Dynamic Frescas was created by this amazing therapist, Maria Teresa Ferrer. I've been lucky to be her teacher assistant for 3 times already, and I've been doing Dynamic Flex Cast for the past 5 years. And this is Dynamic
Yeah.
Flex Cast. This is a cast that it can be customized depending on, like I said, what the child needs, their unique alignment. So we can change the cast. We can do a sturdy cast, or we can do a softer cast depending what I'm aiming for. And that's why you need to know a lot of alignment, a lot of the bone structure, about the function, how the gait is, how the normal gait it looks, what muscle I need to activate in order to improve that gait pattern. So every child looks different. Every child the cast is different. I can make a sturdy cast, very rigid, like this one. this is made of fiberglass, right? This is for a special kiddo. This is for a kiddo that is very severe toe walker, heavy kiddo, teenager, right? An adult that they need more stability and more sturdiness on the cast versus a child if it's a little one is 5 years old, 6 years old, or less than 12 months, it's gonna be a softer cast, and it depends as well of the severity of the foot. If the foot is very severe, we might use more like a sturdy cast made out of plaster, so in that way we get faster results.
Hmm.
If a child is more functional and we get good alignment, we just do this flexible cast that you can bend in
Yeah.
certain areas, like here, so I can strengthen the toes, I can strengthen the push off, but at the same time, I'm gonna keep the stability at the ankle. So in that way, the alignment is right there. I'm strengthening the muscles, but at the same time, I'm stretching the tendon, I'm stretching the muscles, and I'm firing the muscles that I need. So dynamic
Yeah.
flex cast is very unique on every child. Even if I cast the same child, the second cast will look very different from the first cast because we can see and measure changes in alignment in
Hmm.
each cast. I do my measurements, I measure my bones, I take measurements of range of motion, right? I do a cast depending on the child needs. If a child is somebody that has a lot of sensory issues, we can do a removable cast from the beginning, right? And they can wear it for a few hours and then they can remove it and put it back on the next day, right?
Yeah.
If I have a child that is traveling, right, that they just come for the cast, more like the situation that it might happen with the kids that you have right now. I do the cast, I cut the cast, I don't remove the cast. I just cut it, right? I wrap it and I tell the client, you're gonna keep this cast for at least 5 to 7 days. So in that way, the alignment that I will get without cutting the cast is gonna take me double the amount of time in order to get the alignment that I want, but still you will get the alignment. So in that way, in case of an emergency, something happened, the child, is uncomfortable, you just remove the cast, put it back on the next day. Usually, it's very, very rare that you need to remove a cast. It's very, like, very, very rare. I have only one child that it was a curve of learning. He has a unique challenges sensory wise, and is in his case he either need a sturdy cast, very sturdy. He didn't a flexible cast for him was a big no. He
Yeah.
hated, but when I did a sturdy cast, he loved it. So that was the only child I was like, you know what, we need to make it different. But the rest of the clients that I have, I always make a flexible cast because that is preferred,
Yeah.
and because the good thing about the flexible cast versus serial casting, right? That's something that everybody knows and everybody has access to, right? This flexible cast, I can use it for therapy, and that's
Hmm.
something that is very different. The way that it's
Yeah.
made and the way that is is made from the beginning is to be in function. It's not just that I'm gonna get a corrected alignment with the dynamic flex cast, is that this cast is made with a purpose to block the knee hyperextension, a purpose to strengthen the calf muscle, a purpose to strengthen the toes, a purpose to strengthen the extensor muscles, a purpose that increase the knee flexion depending on how I make this cast. So is a good is a great tool because you improving the alignment, but at the same time you improving the function. So a lot of
Yeah.
times when we use the cast, the kiddos they don't want to remove the cast; they want to keep the cast. I have a grandma that she say, "Oh my God! Every time that I put the cast on, he wants to run." I'm like, "Of course, he feels
Yeah.
more stable with the cast. He can fire the muscles better. He can increase the knee flexion better. He feels that it's holding him in place, but at the same time, make him fire the muscle that he needs to fire in order to run. So that's why you
Yeah.
see him running and you see him jumping like crazy
Yeah. That's
when he
cool.
has this on because it gives him the proprioception. It gives him the sensory feedback that he needs.
Yeah.
the stability that he needs that we were discussing before, the alignment that he needs to feel free to move more. And that's something that you don't get with something like a rigid cast, serial casting, or brace, a rigid brace. So that's the beauty of dynamic flex cast.
Yeah.
And and yeah,
Yeah.
you can, like you say, you have
Yeah.
seen the changes in my kiddos. They, if
Oh
it's a
yeah.
heavy, we always say, okay, we're gonna throw the brace, we're gonna
Yeah.
throw it in the garbage. Now we have this, and they don't go
Yeah.
back to use braces. They always use this and just use regular shoes because
Yeah.
that's what they need. Like they look so good that you need to think about and sit and, okay, what's the side that is compromised here, because they look alike that you don't even know after a while using the dynamic flex card which is the side that is compromised. And that's
Yeah.
something that I always joke a lot in my Instagram. Okay, which is the side that is impaired?
Yeah.
And a lot of times nobody know which is the side because it looks that good
Yeah.
that
No, it does. Your
it's,
results are
and that's what
awesome.
we are aiming here.
Yeah. Yeah. I think
From
if
the entity
whoever does it,
perspective and from the dynamic cast,
yeah.
we're aiming for normal or
Mhm.
almost normal on age appropriate skills, age appropriate alignment. We're looking for that view from that perspective.
Yeah.
And I'm not surprised that the person that created that is has an NDT background as well. She's NDT trained as well. She's
Oh,
Colombian
100%.
as well.
I figured that.
It's the same of the same,
But that's an NDT
the same
person
of
because
the
I think
same.
the stuff that like I think sometimes too when you like appreciate that and you really get to know the body, you're like, there's a lot of stuff that people are like, how do you, where do you do that from? I'm like, it's just like your thought process, and you can create like I'll create little garments and I'll create different stuff with different
Oh
tools.
my God.
Sometimes
I'm
I get
so obsessed with those
it
garments that
right.
you create. I need to go to your clinic and see how you do those. I might
Yeah,
need
and I
some.
to me that's it's fun, but it's also like okay, but how can I create? I know I can create this to get that feedback, and then it's kind of like when the child goes home because the more feedback you can give them in that alignment or keep them there or whatnot, the better, the quicker your results are going to be. And then like a lot of times you can take that garment or whatnot away from them after and they can maintain it. And that's like the coolest thing is like when you're like, man, I used to, I mean, I always have to do, I would love to do progression pictures. So some kids come in here and I literally am like blocking this, blocking that. And then like now they've been so many intensives and now they're not wearing like hardly anything, doing a lot of cool things. Right. And um, so it's like, but it's fun to do that. Yeah. So when I saw that, I was like, oh, that's for sure someone that, yeah, NDT trainer, you're just like thinking of that process of how important
Mhm.
that is. So I think when you're like, oh, they don't let OTs get trained, I was like, oh, because that was my next thing. I'm like, oh, I would love to do that. And I was like, I already know what to cast tonight, but I understand that and I appreciate that. So I'm like super pumped about when you come here. Some of the kids that I see, I would benefit, I think, a lot from those, and they come a lot to my clinic and do intensive. So I'm super excited because I think I'd love you'll probably see some before and after just even with that. And I know you're really talented and amazing at that, and your results speak for itself. So um, I think people need to head over to your page too just to see it because it's a really cool thing, and I think I'm loving all this like innovative stuff that like is changing kids' movement and awareness and like just body movement. It's just as much as I love movement, I always say like movement is my thing. Like even working with like the athletes and looking at a child athlete differently and like being able to realize that, oh, they need fascia, they need this, they don't have good awareness, and then see a change. And it's just so cool. And the fact that, I think just bringing more awareness and getting more people to really, really appreciate using all these tools and treating this way just because it would help more children
Yeah.
big time, with their independence and
Yeah.
their movement and preventing, like you said, the pain and the deformities that we see over time if we're not addressing things and giving kids proper treatment. So, but yeah, so
Yeah.
thank you.
I told Maria about you. I
Oh
told
yeah,
Maria about you. I'm
you
like, if
let
you
her
in the
come.
future, if you
She wouldn't
open
even let me
this
come, and then she could say,
OT,
"No, you can't do that. You're not
Jenny
good."
will be the first one. No,
Yeah,
I told her like you need
yeah.
to see her Instagram, like how
Oh,
amazing she
yeah,
works with these kiddos that you don't. that you forget that she's an OT because
Yeah,
she's so amazing and doing gait and facilitating everything that I told her, like, to be honest, I have seen her work and I have so many conversations with her that I think
yeah,
one person that understands the biomechanics is Jenny, because
yeah,
she knows how to use braces, she knows how to do posting, she knows how to do different tools in order to
yeah,
get that, to help that brace to be a little bit more functional. So I think,
yeah,
like, we know that, you're not an, how can I put this in a very um good way, but you're not an average OT. You're not just an OT.
yeah.
You're Jenny. So you
Oh,
know what you know.
well, thank that's
And
very nice.
you have your background in manual
Yeah,
therapy, you have your background in fascia work, so
yeah,
you have a huge knowledge of alignment and
yeah,
bone and ligaments and muscles, that you know the
yeah,
entire body. So I was telling
yeah,
Maria, like, I know she can manage dynamic flex cast because I have seen her work. So I told her,
yeah,
like, just, when you think about OT, the first one that I'm gonna reach out is Jenny, because I know she's gonna
yeah.
do amazing
Just tell her she
on
can train you.
doing
Then she's like, no, you
dynamic,
can't
like,
do it. You're
like
terrible at it.
yeah.
Or,
but
um,
but
but
like,
I'm glad you're
and
calm.
that not every OT has
Yeah.
the knowledge. Not every OT has the knowledge that you have.
Oh, yeah.
Just
Or
just
that,
to put it
yeah.
out
Or the
there.
experience too. But thank you. I
So,
appreciate that.
you have very
Yes.
skillful
So let me
therapists.
come do that flex casting course, right? Just kidding. But thank you so much for all your time tonight. I think, I'd love to we'll probably do some more podcasts and dig in deeper to different topics because I think we have um, a lot of knowledge we can share with people and just experience in different cases where I think showing parents just different things that we use in the effects we're getting and the function we're getting after. And I think we just have some cool things we could probably share beyond this. But thanks again for your time, and I will talk to you
Thank you so
later.
much, Jenny.
We'll see you later.